pleasure and privilege to welcome you to the official opening press conference of the International Liver Congress 2021, the ILC. So my name is Thomas Burke and I'm the Vice Secretary of the European Association for the Study of Liver Diseases, otherwise also known as EASL. And EASL is of course the convener of the ILC. So please welcome to this official opening press conference that we hope will set the tone for the coming days ahead of us. Well, as you know, because of the COVID pandemic, we are hosting now for the second year a fully digital event. So it's no coincidence that we have subtitled this opening press conference COVID-19 and liver disease. I think it's fair to say that at the beginning of the pandemic, liver and liver disease were not so much in the focus. So it was more age, cardiovascular disease, diabetes, were reported as the main risk factors for COVID-related morbidity and mortality. But with the time when the virus spread, we really realized more and more that liver involvement is quite common in severe COVID-19, and also that patients with certain liver diseases carry a higher risk of a more severe course and even mortality. Moreover, it turned out that it's not only the infection itself that affects the life expectancy of patients with liver diseases, but also the pandemic-related change in healthcare delivery. So the International Liver Congress most certainly takes on extra significance this week. And I think the programs that has been organized include some very strong reflection on the intersection between hepatology and COVID-19. You will hear today from our speakers and during the course of the week at ILC how the pandemic impacted the incidence and severity of alcohol-related liver diseases and the demand on liver transplants. There is a WHO goals to eliminate hepatitis C virus with certain aims, and we have learned that also the pandemic affects all our attempts in order to eliminate hepatitis C worldwide. How coronavirus impacts obese people and those people with liver and non-alcoholic fatty liver disease called NAFLD, this has become a major concern. I think you are aware that approximately 25% of the world's population are suffering from fatty liver disease, and data are emerging that these people are at special risk for severe COVID-19. So it raises the intriguing question of whether the global obesity and NAFLD pandemic is also a reason why this pandemic is hitting us particularly hard, so whether it affects a already vulnerable population. So we have already seen some media attention on a study being presented this week, genetically linking obesity in mothers to NAFLD in their offsprings. And in Friday's press conference, I understand that we will hear a major announcement on treatment of NAFLD. And finally, as countries are now continue to race to vaccinate against SARS-CoV-2, there is a very important question whether all people and patients with certain liver disease are in a similar way protected as we have seen from the big trials. So before introducing my esteemed guest sitting with me here today, please let me run through some of the housekeepings. So please be aware this live press conference is being recorded. So it will be available on EASL YouTube page shortly after it has ended. Today we will be hearing brief remarks from all our speakers, and then I will open it for questions from our media representatives attending today. So I would like to ask all our journalists sitting in today to please mute themselves, and to ask, if you ask a question, please send it via the chat box, and please, it's very important, indicate your media outlet and who you would like to direct the question to. And we will then direct the question to the nominated panelists. If you want to ask a question verbally, this is also possible, and please indicate this with a raised hand so that we can turn on your microphone. And please, we try to have short answers, so please also to keep your question brief in order that we have as many questions answered as possible. So I think we are okay now, so let's begin. And again, it's a great pleasure to invite our first speaker and to introduce our first speaker. It's Professor Vincent Mallet. He's a managing senior physician and professor in the hepatology unit at the Cochrane University in Paris, France. And Vincent will briefly describe the impact of COVID-19 on people living with chronic liver disease in France. So, Vincent, please, go ahead.
Professor Berg, thank you very much, dear Thomas, my good friend. So our presentation is, we're very happy to show our results. So what we do in Cochin, in my university, we work with big data analytics, and we wanted to answer to the question, wanted to know the prognosis of French patients with chronic liver disease as a hepatologist, and look at the outcomes. So we studied the outcomes, and we looked at two outcomes: mechanical ventilation as a surrogate of severe COVID-19. And we looked at mortality, in-hospital mortality for all COVID-19 patients in France in 2020. So basically all patients, so that covers the two pandemic waves in France. During the period, it was about 260,000 patients. And so we looked at these two outcomes, and we focused on all factors associated with mortality, the one we read in 2020, and we focused on liver disease because as a hepatologist. And what we observed is that patients with mild disease or compensated cirrhosis or organ transplantation, including liver, and were not at risk for COVID-19 mortality, but at higher risk for mechanical ventilation. So patients were more severe, but at the end of the study, it was censored, and we stopped to observe patients on December 31, 2020. Mortality was rather the same. The surprise, when we looked at these two surrogates, is that patients with alcohol use disorders, and I'm speaking of multivariate analysis, and patients with advanced cirrhosis, either the compensated cirrhosis or liver cancer before COVID-19, were at higher risk of mortality, and this was consistent to the early published papers in 2020, but at negative risk for mechanical ventilation, which was counterintuitive and very surprising. Therefore, these results, these observational results, suggest that for these patients, including patients with advanced cirrhosis and patients with alcohol use disorders, had a limitation of the therapeutic effort compared to other patients and did not have access to mechanical ventilation. In France, in 2020, where we have an unconditional access to care. So basically, our study has exposed health inequities in our country, and we think that our results warranty policy-level solutions, this is why I'm very happy that the EASL selected our presentation, because we think that a strong mission should come from our health, our society, in order to profit from these lessons from this catastrophic disorder, and to leverage new policies in order to improve outcomes of our patients, including patients with advanced liver disease and patients with alcohol use disorders. That's our message. Thank you.
Yeah, thank you very much, Vincent. I think it's a really important message, and perhaps a bit expected from our all-day clinical practice, but I think it has never been shown so clearly as in your national and population-based study. So we would like to move forward and to our next speaker, which is Dr. Martin Uriel Vasquez Medina. And Martin is a researcher with the Laboratory of Biomathematical and Biostatistical Modeling for Health at the Escuela Superior de Medicina in Mexico. So Martin will talk to his research on the impact of COVID-19 of people living with metabolic or non-alcoholic fatty liver disease. Over to you, Martin.
Well, good afternoon. It's a pleasure to be here with you. I am going to talk about the influence of this metabolic dysfunction associated fatty liver disease with mortality in COVID-19 patients. Well, MAFLD is one of the most prevalent conditions worldwide. It is estimated to be the most frequent liver disease. In Mexico, MAFLD is a public health main problem, and it is present in more than 30% of the population. MAFLD was redefined from non-alcoholic fatty liver disease in 2020. The main difference is that MAFLD focuses on metabolic dysregulation as the root of the condition. And it also has positive criteria instead of being a diagnosis of exclusion. Well, it is well documented that patients with persistent liver conditions like cirrhosis or cancer are considered to have an increased risk of morbidity and mortality of any kind of infection, including virus. So the aim of this work was to explore if MAFLD was associated with mortality by COVID-19. In addition, we also explore that if the elevation of transaminases observed in a great percentage of COVID patients could also influence the worst clinical outcomes. It is not been fully elucidated that MAFLD could, is associated with mortality. There are several reports that have shown that MAFLD is associated with an increased risk of having a severe condition by COVID-19. So we perform a retrospective study with 384 patients with confirmed infection by SARS-CoV-2 in the Central Military Hospital in Mexico. We performed a multivariate model adjusted for possible confounding variables, and they were adjusted to age, sex, and main comorbidities. In the adjusted model, obesity, hypertension, MAFLD, and elevated transaminases significantly impacted the mortality. As it was a multivariate analysis, we cannot say that these results for MAFLD and elevated transaminases were influenced by confounding variables. Our results show that patients with MAFLD had 5.1 times more risk of dying during hospitalization than the group control, while the group with elevated transaminases have 2.9 more risk than the control group. Therefore, we have to consider that conditions with metabolic dysregulation, such as MAFLD and obesity, that are characterized by low grade of chronic inflammation, could overlap with the acute pro-inflammatory state caused by COVID-19 infection, resulting in an immune system dysregulation with excessive release of pro-inflammatory mediators, the cytokine storm, that could lead to more severe condition by COVID-19 or even to multiple organ failures. The result of patients with elevation of transaminases could be explained by some reports that have shown that patients that have died by COVID have a lot of them have alteration in the liver, as is the second most frequent organ affected. And we also wanna show with this result that Latin American countries that have these public health problems as obesity, as diabetes, as prediabetes, could be associated with this increased risk of COVID-19.
Yeah, thank you, Martin, for this clear presentation of your large-scale study. So we move on with our next speaker, which is Beatriz Mateos Munoz, and she is a PhD specialist in gastroenterology and hepatology at the Hospital Universitario Ramón y Cajal in Spain. And Beatriz will discuss the efficacy of tenofovir, this is a hepatitis B treatment, for reducing the severity of COVID-19 infection in chronic hepatitis B. Please, Beatriz.
Well, good afternoon. Thank you for the presentation, and also thank you to ISL committee for giving us the opportunity to present our work called Tenofovir, Reduce the Severity of COVID-19 Infection in Chronic Hepatitis B. As all of us well know, COVID-19 pandemic started in December 2019 and has become the most important health challenge in the last decades. In the first half of 2020, a Spanish study showed that HIV patients treated with antiretroviral schemes, including tenofovir, presented less incidence and also less severity of COVID-19. So the aim of our study was to analyze the severity and also the incidence of COVID-19 in chronic hepatitis B patients on treatment with tenofovir or entecavir, and also to do a comparison between both therapies. For that, we perform a multi-center retrospective study in 28 Spanish hospitals. We collect all chronic hepatitis B patients on treatment with entecavir or tenofovir who were diagnosed of COVID-19 between 1st February to 30th November 2020. We analyze incidence of severe COVID-19, ICU admission, mortality, intubation support, and all risk factors. We perform a bivariate analysis between group of treatment, and also we estimate the effect of tenofovir on the risk of present a severe COVID-19 between a statistical method called propensity score. Our database search of around 5,000 patients with chronic hepatitis B on treatment identified 117 COVID-19 cases. 67 of them were on tenofovir and 50 were on entecavir. We have to say that in the basal characteristic, we found that the group treated with entecavir presented greater rates of obesity, arterial hypertension, ischemic cardiopathy, and diabetes mellitus. But if we talk about COVID-19, we found that there was no difference between incidence between both groups in incidence, but the patients treated with entecavir presented more often severe COVID-19, needed more ICU admission, needed also more ventilation support, had longer hospitalization, and also more of them died. In the multivariate logistic model, adjusted by age, sex, comorbidities, and liver fibrosis, we found that tenofovir reduced sixfold the risk of present COVID-19 comparing with entecavir. So our results conclude that tenofovir seems to exert a protective effect from severe COVID-19 in patients with chronic hepatitis B.
Beatrice, thank you very much. This is really a remarkable study comparing two different commonly prescribed hepatitis B medication and the different outcomes. So we move forward, and I would like to introduce now Professor Abdelaziz Shaheen, who is assistant professor in the Division of Gastroenterology and Hepatology at the University of Calgary in Canada. And Abdelaziz will briefly describe some work he has undertaken on the impact of COVID-19 on alcohol-related liver disease. Over to you, Abdelaziz.
Thanks, Professor Berg. It's my pleasure to be here and present to you our findings. Our study basically focused on what is the impact of COVID-19 on the care we provide to patients with end-stage liver disease or cirrhosis, as well as alcoholic hepatitis. As we all know, in March 2020, most of the Western world went into lockdown, and all the care we provided to patients switched mainly to virtual care. And also, it is reported that there is a significant increase in alcohol sales across Europe and North America during the early months of the pandemic. So our study focused on evaluating the impact of the restrictions having with COVID-19 on the care provided to end-stage liver disease as well as alcoholic hepatitis. So we compared two eras between March 2018 to March 2020 as our reference pre-pandemic care to post-pandemic between March to September 2020. And we identified all the patients who were hospitalized for non-alcoholic cirrhosis, alcohol-related cirrhosis, and alcoholic hepatitis in the province of Alberta. And Alberta is 4.5 million, and we have a single payer care, so all the patients could be captured in our database in Alberta. Interesting results, we identified that the characteristics of the patients admitted post-pandemic to pre-pandemic didn't change for non-alcoholic related cirrhosis and alcohol-related cirrhosis. However, for alcoholic hepatitis, we identified patients are admitted at a younger age and mainly from rural areas. And we looked also for ICU admission and inpatient mortality to reflect on the severity of the disease. Interestingly, ICU admission for those patients did not change after the COVID-19 pandemic. In fact, for non-alcoholic related cirrhosis, we found decrease in mortality among non-alcoholic cirrhosis patients post-pandemic went down from 11.5% to 8.5%. The striking and alarming results we found a 9% increase on monthly average for alcoholic hepatitis admission post-pandemic. That means months after months after March 2020, we found increase in admissions for alcoholic hepatitis. The admission rates for alcoholic and non-alcoholic cirrhosis did not change. There was a slight increase. That slight increase kept going after the pandemic, but we did not see an inflection point or a striking point such we have seen in the alcoholic hepatitis. Our results actually show that the increase in alcohol sales post-pandemic will impact significantly the natural history of alcoholic liver disease in Canada and most probably in Western world. Thank you.
Yeah, Dr. Lazic, thank you very much for this very clear presentation of your data coming from Canada. So our next speaker is Mohsen Subhani. He's a hepatology PhD fellow at the Nottingham University Hospital from the NHS Truster in the UK. And Mohsen will look at the effect of COVID-19 on alcohol use disorder among hospitalized patients. So please, over to you, Mohsen.
Thank you very much, Professor Berg, for your kind words. So I'm Mohsen Subhani. What I'm going to present today is first alcohol use disorder in hospital setting, and the second impact of COVID-19 pandemic on alcohol use disorder. So what we have seen over past few months that in UK, Public Health England reported sadly the alcohol-related mortality in UK hit record high since 2001, with a 20% rise from last year. And sadly, one from most deprived area, one who were hit hardest. And moreover, the off-trade sale of alcohol increased as high as like 29% during pandemic. So what we did in Nottingham University Hospital, so we went back and tried to look into what was happening before pandemic and during the pandemic. So we had two cohorts. Pre-pandemic was from April to October 2019, and pandemic was during April to October 2020. And in Nottingham University Hospital, what we do, all hospital admission since 2018 have a mandatory alcohol assessment by Audit C-score. So Audit C-score is a validated tool recommended by WHO and the NICE for alcohol assessment, and it gives us a risk category based on the score into low risk, increased risk, high risk, and alcohol dependent, and a score above 5 deemed as screened positive for alcohol use disorder. So we screened almost 50,000 patients and finally included over 47,000 patients with pre-pandemic 27,000 and pandemic over 20,000 patients. And what we observed, actually the important findings to highlight that during pandemic, the number of admission actually significantly reduced from 36,000 during pre-pandemic period to 27,000 during the pandemic. And then looking into the people who were screened low risk for alcohol use disorder or screened positive for alcohol use disorder. So in pre-pandemic, 18.6% versus 17.6% in pandemic was screened positive for alcohol use disorder. In both cohorts, the majority of the patients who were screened positive for alcohol use disorder were male, of white ethnicity, and significantly younger than low risk group. So the age difference for at least 8 years, that was mean age difference. What other interesting finding we observed is that during the pandemic, the patient who were screened positive for alcohol use disorder were more likely to be alcohol dependent. So before pandemic, all the admission during that time period, 3% were actually alcohol dependent versus during pandemic, it went up to as high as 4%. And interestingly, what we observed, a shift in the social situation, like more people who were screened positive for alcohol use disorder were likely to be in a relationship compared to pre-pandemic. And interestingly, I think something that we have observed over decades, the alcohol paradox that most deprived hit hardest, but during pandemic, what we observed that a significant higher proportion who were screened positive for alcohol use disorder were actually from least deprived area as compared to pre-pandemic. And interestingly, then other important thing that we always worry about, the link between alcohol misuse and mental health disorder. So what we observed that in both cohort, as alcohol use disorder go worse from low risk, increased risk to alcohol dependent, the risk of mental health disorder proportionally increased. But importantly, during pandemic, a significant higher proportion had mental health disorder associated to alcohol compared to pre-pandemic. Then the other important last thing to highlight, the inpatient mortality among the patients who were actually diagnosed with COVID-19 infection. So the risk of inpatient mortality was higher, whether they were low risk for alcohol use or screened positive for alcohol use disorder. But interestingly, the one who was screened positive for alcohol use disorder died at least 8 years younger than who were low risk for alcohol use disorder and had concomitant COVID-19 infection. So conclude, what we wanted to highlight from this study is that people who were admitted during pandemic and screened positive for alcohol use disorder were more likely to be alcohol dependent, were more likely from higher socioeconomic background in a stable relationship, and more likely to have mental health disorder. And if they died inpatient, they died at significant younger age. What we're hoping from this study that to implement that idea of social segmentation to identify these high-risk group and implement early identification followed by intervention. And as other speaker mentioned, to prevent the future long-term harm when we all worry that all the liver patients present at a late stage when the scope of an intervention is minimum. Thank you.
Yeah, thank you, Marcel, very much. It's really remarkable how fast, in what a short period, really the characteristics of the population changed. I think we wouldn't have expected this, that it occurs so fast. So we're coming to our final speaker today, and this is Professor Rifat Safadi. And Rifat is Professor of Medicine at Al-Assad Hebrew University Hospital in Israel, and will share with us today some fascinating results on the immune response of people with advanced liver disease to the Pfizer-BioNTech COVID-19 vaccine. So please, go ahead, Rifat. Rifat, are you with us? Can you hear me?
Yes, sorry, I did not.
No problem, please.
Okay, well, thank you for the introduction. Indeed, in Israel, we had the chance to vaccinate until now almost 96% of the adult population who are 16 and above. And just recently, a week ago, we started to vaccine the young people between 12 years and 16. That is an amazing operation that actually have been published also with the results in the New England Journal of Medicine to decline the COVID-19 incidence, severity, and the COVID-19 related death. So I was wonder whether this is affecting our liver patients and how we can start with that. Unfortunately, we had in my center 41 liver transplant patients who were infected with COVID, and we lost 2 patients who died from this infection. Luckily, with the vaccination and the extremely significant results that we had it globally in Israel, the last 3 months, we do not have any recorded transplant patient with COVID-19. Was that a result that they are vaccinated? Or it is a result of the population vaccination? That was the question. So we evaluated the vaccine response within about 110 transplant patients who received the Pfizer vaccine, 2 shots, 3 weeks apart, and the response have been evaluated after at least 1 week, and the endpoint is a failure, which was characterized as either not responding with antibodies, the S-IgG antibodies, or COVID infection. Among those patients, 60% have been vaccinated, very nice, with good titers. However, the 40% did not. 5% of them actually have been infected even after the vaccination. Therefore, the 40% failure indeed looks like as a result of the immune suppression. However, the very nice result to decline the disease within our transplant patients is more related to the general population vaccination. Then I looked further whether the severity of liver disease in non-transplant patients, and commonly the fatty liver disease, is affecting response to the vaccine. So I had 2 pilots, and the bottom line says that the more fibrosis, the less efficacy. And the efficacy is actually evaluated more as a serological response. And I showed that the advanced fibrosis, as well as age, actually is going on with lower titers. Now you can tell me what's the hell of titers? Titers is high, is actually a responder. Why it is important, low titers and higher titers? It is important. Since titers are going down within time, I have a preliminary data showing that within 3 months, almost 50% of the titer is declined. So we still with the COVID. Just recently, we have importing the Indian mutations. Therefore, we have to think further and longer, and we have to think about the booster of the third vaccination. And I see that there is a responsiveness that is coming from our Administration of Health, that we are thinking now about boosting a 3rd shot, especially those with high risk for non-responsiveness or lower response. And actually, the fibrosis was the most important biomarker that can be evaluated either by FIB4, and I have a pilot of 719 patients, or biopsies, and I have a pilot of 150 NAFLD patients, and I have also another 60 patients with NAFLD evaluated by FibroScan. All of them are telling that the more fibrosis, the lower response. Now I'm just going to start to boost my transplant patients who failed to develop any serological response with a 3rd vaccination, and I hope that within 3 months I will tell you an update. Thank you for listening.
Yeah, Rifat, thank you a lot. I think really from the Israel experience, we can really learn a lot, because we really are collecting all the data from your huge population-based vaccination strategy, and that's really revealing. So we are here at the end of the short presentation from our experts. Thanks again to all the experts for summarizing their results that will be later presented at the ILC. And I would like to invite all the journalists again to send in their questions via the chat or to raise the hand that we can see that you would like to go to the microphone. There's already one question coming from Germany, from Ingo van Thiel from the German Liver Aid. And the question goes to Professor Mallet. Vincent, to you. And the question is whether mild chronic liver disease in general, so this means early stage hepatitis B, C, hemochromatosis, so not liver cirrhosis, is still considered to not increase the COVID-related morbidity and mortality risk, or because of your data, is it now considered to increase the risk to some degree too? So according from the abstract, it seems to suggest that all stages of chronic liver disease had an increased mortality risk.
So overall, chronic liver disease increased the risk of mortality. If you look in clusters and including mild liver disease as you defined, as Professor Berg defined, was not associated with an increased risk. Mortality was clustered to patients with advanced liver disease, including patients with prior decompensated cirrhosis before COVID-19, patients living with hepatocellular carcinoma, and of course, patients with alcohol use disorders, regardless of liver disease. So mild liver disease, including HBV, HCV, as the journalist said, as Mrs. Steele said, was not associated with an increased risk of death.
Okay, yeah, I think that's a very important message. So are there any other questions coming from you? Well, perhaps coming to Beatrice, to the data of tenofovir and entecavir, perhaps we can explain to the journalists that entecavir and tenofovir are now very cheap drugs that are widely used. There are already generic drugs available throughout the world to treat hepatitis B virus infection. So how clear is it really from your data that tenofovir might be a good drug, or do you have concern that the opposite is true, that entecavir or patients being on the entecavir, it's harming? Could you please comment on that?
Yeah, well, we have to consider that our study is a small size. I mean, that we can conclude or make drastic conclusion about it, but I think that maybe in patients that has to start antiviral treatment and has not any contraindications to tenofovir, maybe it's a good point or a good sign, this study, to start tenofovir in this time of pandemic than entecavir. But obviously we need more data and bigger populations to have conclusions.
Yeah. Are there any cell culture data supporting that tenofovir might be protected?
Well, there are in vitro studies that shows that tenofovir can link to SARS-CoV-2 polymerase, so maybe it could make an antiviral effect to SARS-CoV-2. And also we know that tenofovir has an immunomodulatory effect that maybe can promote Th1 response. That is the opposite of the one that's that occurs in SARS-CoV-2 severe cases. So maybe these two things are related with the effect that we have seen in our results.
Yeah, that's a very good point. Thanks a lot. Perhaps I may continue asking a question to Mo-san. So I think the increase you have shown here in the admissions and also how the population changed, as I mentioned, it's really, very much also concerning. So have you followed on this? Is this trend still continuing? Have you seen that there were differences in the first part of the pandemic and the second part? What do you think will be the future outcome of what you have observed?
Thank you, Prof. Burke. So I did time series analysis just purely based on admission. So just all the admission irrespective of alcohol or not. So there is a positive trend, and that was significant. Regarding alcohol misuse, so we do have data now up till May this year, which we're planning to do as per UK government restrictions, starting from before restriction. So comparing each 4 months to other one to see what is the difference there. So I think what we're hoping to see is that what we can get from this one and this idea about social segmentation, where you know where high risk groups are coming from, and then you can target them. And as all of us are quite well aware of the Lancet Commission report, the UK talking about the majority bulk of the patient with any risk like NAFL or alcohol present at a stage when any intervention doesn't offer more, and the reversibility is not possible. So I think this is the opportunity for us to early intervene. We have a reshuffled our alcohol care team, and we are now following this patient into community as well. So we're hoping to see improvement from that context.
Yeah. Okay. Thanks a lot. There is a question coming also to Rifat, but first there's a follow-up question for Virginia. So with the tenofovir and entecavir study, the question is coming from Virginia Baquier from APM Paris. So the question is whether with the tenofovir entecavir study, whether the risk difference is mainly driven by patient profile differences. Could you please answer to that, Beatrice?
Yes, thank you for the questions. We selected a statistical analysis, a propensity score, a special propensity score, which was adjusted to age, sex, comorbidities, and liver fibrosis. So I think that our results could avoid all of these confusions factors that we found in our population on the basal characteristic.
Okay, thank you very much again, Martin. And then again, a question coming from the audience, again from Ingo van Thiel from the German Liver Aid. And it's going to you, Professor Safadi, Rafet.
Yes.
The question is, this will trouble a lot of patients, the results of your study, who will eagerly wait for booster study data. And the question is, I understood that fibrosis is a major factor for reduced response. So what is the impact of immunosuppression in liver transplanted patients and also in patients with autoimmune hepatitis? This is the first question, and then we come to the second one. So what is the effect of fibrosis and immunosuppression in transplanted and autoimmune liver disease?
Thank you very much. Actually, it is a good question. Indeed, I didn't look for a big series with autoimmune hepatitis yet. We are collecting the data, but the preliminary results showing that they are doing much better than the liver transplant ones. Liver transplantation had a failure of 40%, and we have now sub-analysis showing that the earlier phases are more prone to fail rather than those who are old transplant patients. But actually it is related to the regimen of immune suppression. The more steroids, the more calcineurin inhibitors, and the more MMF are going with less efficacy and less responsiveness. However, the more everolimus is going with higher responsiveness. I don't think that the everolimus was the one to increase the responsiveness, but we use it in order to spare the calcineurin inhibitors and steroids. Therefore, it is allowing the responsiveness to the vaccine. As to any memory for those who do not responding serologically, I guess yes. I didn't check that yet in my lab with the T cells responsiveness. However, we are collecting the data. But I can tell you about one single patient that I already managed to give him a third shot, and from 0, he elevated to a very nice titer. So I think that there is a memory, that there is some responsiveness. I can tell you also that the 2 cases who died and the severe cases from the COVID infection were before the vaccine era. However, after the vaccine era, which is actually almost half of my patients who were infected, they were with easier disease and even without any case of death.
Yeah. So Rifat, thank you a lot. I think also to explain it to our journalists, you mentioned different types of immunosuppressive drugs, and there's really a big debate around all medical societies whether, for instance, for certain drugs you should stop before vaccination. So, and this follows quite well to what you have just said, that could there be still an invisible protection, not by B cells, this means the antibody response that you have measured, but by T cells you haven't measured in the absence of these antibodies. So do you feel these patients are nevertheless protected, at least to some extent, for suffering from a very severe form of COVID-19?
Well, the fact that they have less, those who were infected, they have less severity and less mortality, I guess it is a result of some result. Whether it is a response of the T cells or non-visible B cells, I cannot tell you exactly. We need more data.
Okay, so I think we come to an end for this first EASL ILC press conference. I would really like to thank you all for joining. I hope you find the information interesting. I think you can reach out whenever you want to Michael Kessler from the ILC communications team. If you want to follow up with certain speakers or certain topics, we are very happy, and Michael Kessler is very happy to take your questions. So special thanks to you, Michael, for helping to organize this, and to the EASL office team being in the background, especially Syriac. And I would like to wish you a good day and hope to see you soon, and please stay safe. Thanks a lot. Bye-bye.
Thank you.
Thank you.
Thank you. Bye.
Thank you. Bye.
Bye-bye.